Welcome guys to the chat box today. So a patient gets a road traffic accident close to a high-end hosi in Nairobi. So he comes to hospital and we all agree as the medical doctors that this patient actually requires to go to theater. So we do our preliminary investigations to identify the relatives and whatnot, and we all agree as the medical team that this patient can actually not afford to pay for the services. So what do we do in this scenario? Do we take the patient to theater and have the financial conundrum, or do we refer and refuse to admit this patient? What do you guys think about it, guys?
Well, yeah. So I think it's something, a situation where most private facilities actually find themselves in, because this is not a challenge in public facilities, because we all know if a patient walks in, they are not able to pay. We have the social worker who is eventually going to waive the bill, and the bill is paid by taxpayers' money. And I think the challenge then becomes the accident has occurred in a private facility. And I want to see it in both sides. As a doctor, I actually want to see the patient going to theater because my work is to save lives. But from the point of a hospital administrator is that yes, I will save lives, but who pays for the drugs that I'm going to use? Who's going to pay for theater space? Who's going to pay for my medical team that is going to involve in the procedure? Because even if we were to wait for this one particular case, what happens when there's another case that comes tomorrow? And sometimes even this accident could be a matatu, and therefore I'm getting about 10 to 14 patients coming in. So I think it's something that even the framers of our constitution had actually thought about it. I think Article 43(2) of the Constitution says that no person should be denied emergency treatment. And in fact, we want to understand that the private facility at this point, they're not denying private emergency treatment. They're actually more concerned about what is going to happen, because we actually seen hospitals being sued for providing treatment. Patient was not able to pay, and they detained them, which is actually illegal. We've also seen patients who have gone to medical treatment. They have been treated, and then they were discharged. They got into an agreement with the facility. Your bill was 500,000. So can we get into a plan where you pay over a period of 1 year? And if it's a patient who is not able to raise money, you don't expect them to raise this fund. And sometimes even post surgery, this is a patient you don't want them to go back to work. You want them to go home and rest. I think from the point from where I stand, I think it's high time that the government actually operationalize that section of the Constitution, that nobody should be denied emergency treatment. But that responsibility actually falls on the state. It doesn't fall on the private healthcare provider. It falls on the state. I think now, if as a private facility we provide that care, we take the patient to theater, we provide medication, we watch them post-operation, we take them to the ward, and they are able to go home, then there should be a mechanism in which then the government is going to reimburse me of this cost.
And Roger, back to you on that. That's a very sound answer, but I'd like to get your opinion, Dr. Libeya. What do you think?
Pretty much reiteration of what Dr. has said. And I think for a long time I've heard that statement being uttered time and again, especially in line with Article 43, as you rightly quoted, that no person should be denied emergency healthcare services or treatment. And nobody chooses where an accident happens. And spread across the country, we well understand that we have the public healthcare system, and we also have the private healthcare system. The public healthcare system, how it is funded, is slightly different from how the private healthcare system is funded. And of course, if I decide as a person to venture into private healthcare system, of course, I'll be offering healthcare services, but the sustainability of my business is on business principles, right? So, of course, there is that humanity aspect and call of duty that I have to protect and preserve life by offering emergency services. But the question that will linger at the back of my mind is, after I've served this patient, what happens to paying my workers? Because they are not being paid by government. So who will foot the cost of paying them? Who will foot the cost of paying the utility bills? Who will foot the cost of paying the rent if the place is rented? So all that has to come into factor and to be considered. So if we are saying nobody should be denied emergency services, then do we have mechanisms that actually shall ensure that this person is correctly compensated after they offer the service? And in fact, if the system is in place and I'm a doctor in a private facility and I have such a patient, I'll focus on what I do best, delivering care to save this life. The aspect of compensation will come later on because I'm guaranteed that there's a system that ensures I'll be rightly compensated for this emergency that I've attended to. So, rightly as you've put it, it's high time that the government activate that particular provision in the Constitution of emergency funds, so that even as we have these cases, no Kenyan should die or should be asked, deposit first your title deed.
That actually happens to most facilities.
That happens.
You walk in and the first thing is that you're paying cash or card
or the logbook.
And because they need security before they take you to theatre.
Okay, very good point as well. So back to my question: how exactly does the government come into this? Like, how can they confirm that the patient actually came? Because if I, as Austin Omondi, walk in, and Kenya is a country full of very many wakoras, right? How can they prove that Austin actually came into this center, and we as the government owe you some money at the healthcare facility? How can we harmonize that? Because previously with NHIF health centers which were being paid and yet they never saw patients. You have a center that is the size of a kiosk being paid hundreds of millions. So how does the government harmonize that to actually prove that this particular center actually needs to get paid?
Well, so first, I think we are all agreeing that the responsibility falls on the state to provide to actually breathe life to this particular provision of the Constitution. And I think there was an act around the Health Act 2017 had tried to actually to operationalize that section of the law of the Constitution. However, we haven't seen much going into it. So, and I think I will marry your question by saying, there were complaints that were made, especially around NHIF, and I think we saw on the news a few hospitals which were quote unquote exposed. Now we have a new law in place, social health insurance fund, which comes into 4 different laws, and one of them is digital health.
For sure.
I think this is where we leverage technology to actually prove to us that actually you provided care. And I also see a point where KMPDC will have to play a more proactive role than a reactive role. We've seen when complaints are lodged, that's when investigations begin. But we should have a mechanism in place where if a patient is served for emergency treatment in my facility, I should be able to lodge that claim for that money, say within 12 or 24 hours. And then this claim, before it goes to the social health insurance, if that's the person, if that is the entity to pay, and I think your question was on NHIF. I would say, for example, before that claim is taken to NHIF previously, that claim should go through KMPDC, who will then will come to ascertain that there is actually a patient in this facility who was involved in an accident, was brought in here. This is the procedure that was done, and KMPDC is actually the custodian of the cost for every procedure in the country. We have a document from KMPDC that shows how much should be paid for every procedure. Once they ascertain that this is what was done, an X-lap was done, exploratory laparotomy was done, then there was damage to the intestine, so there was resection and anastomosis. There was a stoma that was left in situ. All that is costed
Okay.
The point now the KMPDC will say the actual cost of this treatment matches the claim that has been submitted by the facility, and that now is forwarded to the insurer who is going to pay. And we must appreciate the effort that the country, Kenya, is actually taking towards this. We now have a law that is seeking to operationalize not just emergency fund, but emergency critical and chronic fund. And I think this is a pool of funds that is supposed to reimburse such such situation and such claims. So I would imagine that if such a claim is lodged within 12 to 24 hours, the KMPDC comes and ascertains that the claim matches actually with the service that was provided, and then the claim is actually forwarded to emergency and chronic critical fund, and reimbursement again we should have timeline. There's something that we are seeing, that there are timelines to what time you can lodge a claim, but really we don't have a timeline that shows when you should get compensated.
Yeah, for sure.
And that is why we're seeing even facilities closing down, because they are waiting for insurance companies to pay. So we should also have a clause where if such a claim of emergency was lodged within 12 to 24 hours, then we can say within 7 days that claim should be reimbursed. And that allows that facility to be readily operational and be willing to accept even multiple casualty if they happen in the near future.
Very good answer. I think the current time for NHIF is around 90 days per claim.
Yes.
Okay, so back to Dr. Libeya, what do you think the Social Health Insurance Fund can improve on compared to the NHIF in the new dispensation? What do you think that we can improve on? And speak directly to the Minister of Health and speak to the President of the country.
All right.
What do you think as a doctor we can do better, and how can they improve SHIF?
All right, thank you. That's a good question, and just before I respond that, to add to what he has said, I think the significance of controls in place. I'm trying to borrow a lot from private insurance, especially when it comes to motor vehicles. When your motor vehicle gets engaged in an accident and you've covered it, there is a certain window that you've been given to make a report, and then they send an assessor to come and assess, and then give a go-ahead whether you receive a compensation or not. So if the same type of control can be implemented in emergency fund, where we have devolved assessors by KMPDC, as you put it, the regulator, who is also a custodian of costs of different procedures, so that when a report is given or a report is made that we are attending to this emergency in this location, within, let's say, 12 to 24 hours, they're able to send their assessors to go and ascertain that actually this is what they have reported and it's marrying with what is actually on ground, then to give you a go-ahead that this person can be reimbursed for this particular procedure. So I fully agree with that. Now, coming to social health, of course, NHIF has served us. During my internship, I happened to interact with patients who benefited a lot from NHIF. Despite its shortfalls, it still had advantages that came along with it. Looking at areas that can be improved when it comes to social health, number one, I'll put on the shoes of the service providers. 90 days in an environment where you are paying your workers on a monthly basis, where you are paying rent and utilities on a monthly basis, I'll say is sort of discordant. If we can say, if you are paying your bills as a business to ensure that you're continuing, I'm talking now on the side of a private facility. If you are settling your bills to keep or to remain in business on a monthly basis, it only makes sense that your dues are also settled on monthly basis. So you don't end up in or less even. So that you keep your staff motivated, you keep your suppliers motivated because you're settling their bills in good time. So that aspect, instead of 90 days, I'll recommend if SHIF can settle the claims within 30 days or even less, the better, so that we ensure the providers are not always on the edge to run their businesses. Now, on the side of the patient, I look at the coverage. because in some facilities will go with the NHIF, you're told this particular service you have to pay out of pocket because it does not cover it.
Yeah.
So if we can increase the services that are covered under SHIF package, I think that will go a long way to ensure that the patient benefit from that as well. Sure. So those are the two recommendations that I have at the moment.
Okay, as a final statement, do you guys believe that the more you earn, the more you should be taxed, particularly for example, health? Do you think like the ultra-rich or the super earners in the country should pay more for the social health insurance fund vis-a-vis the less the guys who earn less? And then again, the last thing I also want to add is, how exactly do you determine what is an emergency? Because if I do have an abdominal pain, it could be anything. As a doctor, I know that it could be anything. Why would I go to Kiambu level 5 as a public hospital vis-a-vis going to the Nairobi hospital, you know? Because most people assume that the private centers have the best services. So how exactly do we gauge that this is actually an emergency and this is actually something that can be covered elsewhere, for example, in a public facility? Because I believe that the basis of it being an emergency, for example, if you have to go to a private hospital and you have no money, it actually has to be an emergency. So where do we get the balance between the two situations?
So I think the definition of emergency then will be the responsibility of the primary doctor.
Okay.
An emergency is any condition that threatens your life or your health.
Okay.
Right? So if you have malaria, it's an urgent case that we need to address. And there's every other condition based on your medical training. You'll know how much time you have.
For sure.
I'll give you an example. If a patient has a fracture, an accident has occurred outside my private facility, patient has sustained fracture, they have come to my private facility, I've given analgesics, painkillers, I've controlled bleeding, I've splinted or immobilized the limb, patient is comfortable, I do not have to go in and fix the fracture in my facility if the patient is not able to pay. We can always now arrange a transfer to a cheaper facility or a public facility. I'm thinking of it in that manner. But for a person who is outside there, patient has been involved in an accident, for them it's an emergency and they will do well by bringing the patient to the hospital. But upon assessment as a doctor, then you determine whether it's an emergency or not. And if you have to refer, it has to be in a timely manner, in a way that does not further jeopardize the health of the patient. But let's talk about the issue of private and public facility. I think we shouldn't have a distinction. What we should do, we should be able to cost. So that when a patient has that SHIF card, they have the option or the liberty of going to a private or public facility. And now imagine a situation where that this SHIF card is comprehensive. So if a patient walks into a public facility, the challenge has always been not more about quality, but the public facility is likely to lack something that is needed for your treatment.
For sure.
That's the frustration that actually many patients have.
What most Kenyans don't know is that the same doctors in the public healthcare system are the same doctors in the private.
It's just that in this center, I may have a CT scan, and so I'll be able to know what is ailing your abdomen even before I open it.
For sure.
But in some public facility, I may have to open it up to find out. And it could be two ways. It could be a case that I didn't have to operate, or it could be something that actually needed to operate. Think of it this way, that we know the cost of a CT scan is X amount. And that X amount is covered by SHIF card. So if a patient chooses to come to public facility and finds Dr. Omondi there, Dr. Omondi assesses a patient and says this patient needs actually a CT scan. And because Omondi working in a public facility, they don't have a CT scan, you refer a patient to private facility where the card will work. The patient is charged on the card for the same amount they would have been charged if Dr. Omondi actually in public facility had a CT. So let's give, for example, if a CT scan is head CT scan is 8,000. It should be 8,000 both in private
and
in public. So that if I do not have a CT scan in public, you send the patient to private, we run the card, we do the CT scan, and the report and the images are sent back to Doctab in public facility, and they go ahead to do the procedure.
To cut you short, so you're saying we should harmonize the prices in both public facility
and private facility.
But the difference is this: in the private facilities, we look at the consultant is on call, so you're paying extra for also speed. Because in the public system, the quality is still there. But what you actually, I feel like the only conundrum in the public system is the time. But in the private facility, for example, if a CT scan is done, you will not get, in private you get the results faster, in public you might have to wait a bit more because there are more patients and very few doctors. So how will exactly we get a balance between the prices as well?
I think, and I get your point, Dr. I think the point here, first of all, is that we need to understand there is shortage of healthcare workers.
Yes, for sure.
And I think this is something government should not run away from.
And speak to the camera, to
yes,
the president and the CS.
This is something we should all know, that there is shortage of healthcare workers in the country. The reason why a patient will have to queue in radiology department to get an X-ray for a whole day is because there are few X-ray machine and there are few technicians doing the imaging.
And there's only one consultant.
And there's only one consultant to interpret the images. And I think this is the competitive advantage that the private facility have. It's no more of quality, but in terms of even turnaround time. But I want to imagine a situation where if we harmonize, then the patients do not have to queue in a public facility to wait for that one CT scan. Everyone is waiting. In the meantime, half of those patients could go to nearby private facilities. And the insurer, SHIF, does not pay more because a patient went to private facility. They should be able to pay the same amount of money that would have been paid if the patient went to public. And what this will do is that the private facility, again, sometimes is expensive because they have fewer patients. Of course, economy of scale, right? But if you are to harmonize, you'll likely to have good number of patients in private facilities, just as in public facility. And what will happen is that they will be able to cover their cost in terms of numbers. I think we should have that balance. Let's cost the cost of treating diabetes and know that this is the amount of money you need to pay. And I'm thinking from a point of consultation to a point that the patient is leaving the compound of the compound.
Very well said. So as a last comment, Dr. Libeya, there's a very common phrase that I usually say that medical doctors offer services that they themselves cannot afford. So can you just highlight on that?
All right, thank you. That is, I would say a question because not a question, but a request to comment on. But I think it's something we've observed since when I was in school, even after school, and the cost of acquiring services in Kenya is quite high. When it comes to healthcare services. And you realize that a lot of expenses in the healthcare space is out of pocket. But if it's insurance, most of them have a limit. So there is a certain they can only pay so much. And I'm glad that the policies that are coming in place, they're coming to cushion against that so that everybody has an access to quality services without catastrophically spending. So initially, before these laws came in place, doctors are considered to be high earners.
For sure.
I agree and I don't agree with that at the same time.
We have no money. Personally, I cannot afford.
Yeah, we have huge titles, but at the end of the day, what people perceive doctors to have is not actually what is in the pocket. And sometimes they get surprised when you're sick and you call for fundraiser because they say, you're a doctor, why don't you teach yourself? But they don't understand that you can't just wake up and teach yourself.
For sure.
Some services require equipment, and all that, and that comes with a cost. So it ends up that the cover you have as a doctor, it could be the civil servant, initially NHIF, or even a private cover. and it turns out that is not able to foot the cost of the treatment that you need. So that's what we say, that we end up with that statement. We are offering services that we ourselves can't afford. Because you have the skill, yes, but the person who has the equipment and the place where your skill needs to be put into use has set a certain price that you can't be able to meet.
And you cannot pay by with blessings and vibes, you know.
And now that brings me to another point. They say medicine is a calling. That is true, but it's not 100% correct.
Elaborate.
Medicine is a calling, yes, because you are serving out of heart. You find yourself in situations where an average human being may not necessarily find themselves. I mean, they cannot be comfortable. I mean, attending to patients, they are in their worst of situations.
For sure.
So it takes a heart that is beyond an average human heart to attend to those patients with grace.
Yeah.
And one thing that the public don't understand, they tend to extrapolate that when it comes to even rightful compensation. It's not that you are asking much, you're just asking to be compensated rightly, because when you go to a supermarket, you won't pay with a calling.
My landlord does not receive
Your landlord doesn't receive callings. He wants money at the end of the month.
Wants my money.
You see? So the skill is there, you're calling, yes, but the public has to understand that we are human beings, we have bills to pay, we have other things that need money that need to be attended to, and so when we rise up to negotiate for better terms because of inflation, we are coming from that background, that we are also facing the realities of the economy, and we need our salaries to be adjusted so that we're able to live comfortably and serve the public better. So that I had to drive that home.
And I think every time that conversation is brought on the internet, people argue, you know, even pilots fly planes they can't afford. Engineers are building houses they cannot afford, yeah? But on a light note, and I think this is something we have actually seen with our seniors, that I don't remember paying for a consultation any time I go to see a consultant or a senior doctor.
For sure.
Doctors are willing to provide free care among themselves. Right? But if I have to operate on you, then the facility that I'm going to use
will not.
They will never
listen to that.
Listen, you are a doctor or what? You'll have to pay the cost like every other person. And I think that is the point where doctors need to also understand we are part of the community, and if bad policies are made, we are also going to find ourselves in that situation. So if we're going to champion for a good insurance cover for the community, then we should know that that same cover is the one that is likely to save us in a situation that we need medical treatment.
For sure. Yeah. So thank you guys. You've heard from your doctors. I'm your host, Japrado, and come back for more such content.